Hello to everybody joining us online. I'm excited to introduce the Pediatric PH. We're going to talk about the advances in therapies, all the exciting stuff that everyone's here to hear about. We're going to go through a presentation led by Dr. Erica Voorhees. I'm saying that right? She'll come up and introduce herself in a second. We're also going to be joined by the wonderful Jeanette Reyes, nurse practitioner out of Toronto. She'll come up and join us for a Q&A we'll do at the end. So we're going to go through the whole presentation, log your questions down, but it's a small room, so I think we want to keep that super interactive. So get informed, and then we'll try and save kind of 15 minutes at the end for Q&A, maybe earlier, depending how long we go through it. And I'll keep you honest to the time there, okay? Wonderful. I'll pass you over.
Okay. Oh, just going to adjust this because I'm not the tallest person. There we go. Can you hear me? I feel really formal in this big room. Wow. Certainly, as we go along, if you have a question, please let me know, because I think really we have the time to ourselves. We can adjust. I have prepared some stuff because I thought there were some topics that likely many in the room would have questions around. But of course, if it's an area you're like, oh, no, we know all that already, we can move ahead through that, of course. For those of you online, I think John will help us in terms of getting your questions through to the group as well, so we can go over those. John, I'll leave that to you if you don't mind, just to let me know about the online pieces. Okay. If I can just get the slides up. Yeah, thanks a lot. Great. As in anything, it's always important just to make sure everybody knows I have no disclosures. So meaning, again, I'm not paid to do the talk. This is really, again, based on clinical experience and research, what I'll present for us today. And important to talk about that I will present, talk a little bit about off-label use of therapies, of course, because pediatric pulmonary hypertension, we're using most of the medications in an off-label function. Things I'd like to talk about, I picked a few. Again, appreciate you guys can direct me if there's ones that you'd like to move up the list. But I thought I'd talk a little bit about the World Symposium and some of the updates, particularly around the treatment strategy. And then I'll talk a little bit about medications, and particularly focusing on some of the newer ones that we're using in pediatric pulmonary hypertension, macitentan and selexipag, and then talk a little around sotatercept, which certainly has already gotten quite a bit of airtime at this conference already, but we'll talk a little bit about it in the pediatric sense. And then if we have time at the end, we'll talk a little around novel therapy, novel interventions. So a good place to start is always reminding ourselves about the variety and the many, many types of pulmonary hypertension, of which, again, appreciate most of us know each other in the room here, but for those online, there are certainly a large number of types of pulmonary hypertension, even in pediatrics, and the current clinical classification divides pulmonary hypertension into 5 main groups, of which really in children, what do we mostly see? I'm just going to switch the slide. This is data from the Pediatric Pulmonary Hypertension Network Registry, which is a group of a number of centers, both in North America, including Canadian centers, of which here in Alberta we're really happy to be part of this. And this is just looking at the registry, looking at how many kids for each type of pulmonary hypertension are there. And you can see the majority of the kids really have, what do we see? Mostly patients with group 1 disease, which is, again, pulmonary arterial hypertension, or group 3 disease, so pulmonary hypertension related to lung disease. And looks a lot different than what we see in the adult world. Let's see if this pointer even works. Yeah. Where in the adult, this orange wedge is actually really a substantial number of people who have pulmonary hypertension. We have very few kids that have group 2 disease. And if we do, it's really related more to how their hearts are built rather than the strength or the relaxation pressures of the heart. So always interesting to just remind ourselves a little bit how pulmonary hypertension is certainly still different than adults. There's lots of types of congenital heart disease that are associated with pulmonary hypertension. And again, just looking at the diversity of people in the room, I think many people will have a good understanding of that. But for those online, remembering that some types of congenital heart disease fit into group 1 disease, which is what we're going to talk a lot about now moving forward, or pulmonary arterial hypertension that is related to congenital heart disease. But there are certainly some types of congenital heart disease that are attached to the other clinical classification groups. So group 4 and group 2 particular, where we can have different types of congenital heart disease causing that pulmonary hypertension. The other group, as I mentioned, that we see a lot of is pulmonary hypertension related to lung disease. And I just threw this up. It's from the World Symposium, which is an updated table of the more common forms of developmental lung disease that we see attached with pulmonary hypertension. And the two on the top there you can see are starred as bronchopulmonary dysplasia, which is the developmental lung disease of the child of prematurity, or often called premature lung disease, chronic lung disease of the premature child. We see certainly that most commonly, followed by congenital diaphragmatic hernia. Both those diseases come with pulmonary hypertension in various severities. There's certainly a large number of other developmental lung diseases. This table isn't entirely exhaustive, but certainly does have some of our newer diseases that we're seeing in different variations and more commonly now. So nice to, again, for those with us or online, again, you may be a family or have a person in your family's life that does have one of these other diseases with associated pulmonary hypertension. Pulmonary hypertension with lung disease, I'm not going to spend much more time talking about it, a little bit when we talk about the strategies, but it's really has a little bit of a different treatment management plan than what we use for truly pulmonary arterial hypertension. Where in those children with lung disease and pulmonary hypertension, we really have to focus on optimizing the lung disease, making sure those lungs are in the best shape possible. Whereas other forms of pulmonary hypertension where we don't have attached developmental lung disease, that isn't as much a value in the treatment plans. So this is from the World Symposium as well, where the treatment strategy has been updated a little bit. Very truthfully, it's very similar to what we've been working on off of over the last 5 years. And for those not as familiar with World Symposiums, they happen about every 5 years. And it's, again, the entire pulmonary hypertension community, adult and pediatric, around the world that unites to, again, have discussions and then create some adjustments or consensus decisions around particular key points around management, diagnosis, and other pieces in the care of pulmonary hypertension. And so one thing that always gets discussed in those symposiums is the treatment algorithm, and so how we approach treating patients with pulmonary hypertension. And so this algorithm is pretty similar to what we used before. I'm just showing you the first half. What's cool this time, certainly it's got a lot more color, where before it was black and white. We've moved to really color coding now, and the first half of it is really focusing on that major decision of, hey, making sure the whole workup is done, making sure we have all the right testing to be certain we know the type of pulmonary hypertension. And then after that, again, the importance of a right heart cath and getting that additional information to help us really understand the severity and where, again, what type of pulmonary hypertension we're managing there. And then that big decision around calcium channel blocker therapy. And that's why the algorithm got redesigned. This was always in the original algorithm, but it's been designed now, I think, in a way that it really emphasizes that's an upfront decision first. Or is this a patient that would do well on a calcium channel blocker therapy or not? And so that's the first part of the algorithm. For patients, and I'll talk about that on the next half, that have really identified congenital heart disease or lung disease, they, again, typically calcium channel blockers are not necessarily part of their decision-making strategy. So you'll see they meld into the algorithm here in the next step that we'll go into. But the first step of it is making that big decision, and that's typically after, again, that first cath that's done, because we really, in pediatrics, do need that vasoreactivity testing data. We're in the cath lab. We use a medicine to see how well those vessels open up to help us make that decision. This is the bottom half. It gets really colorful and fancy now, but certainly, again, very similar to what we've always been doing, but nice to see it on one page. And it's what's different this year, or I shouldn't say this year, this update of it, is that we've added in now those conditions with congenital heart disease and lung disease. And those are the ones that are living on, for you guys, the right side of the page. That's that arm there, where we really have, again, different managements related to kids with congenital heart disease about closing the holes in their hearts or any other surgeries they might need. And those kids with lung disease, the role of, hey, shoot, how do we get those lungs in good shape? And still, is there an opportunity for some with lung disease and associated pulmonary arterial hypertension to use these therapies? And nice to see it on paper, because we've all been doing it somewhat informally for a number of years about integrating the use of these medications into those kids with congenital heart disease or lung disease. On your left is the other half, which looks really similar to the algorithm that we've always worked off of. But what's really cool is we now have, you can see those red and green boxes. And there's been a lot of work done in the last 5 years looking at risks, both clinical features, echo features, testing, cath lab numbers, to help us decide, are patients have low-risk disease or high-risk disease, which feels very similar to the conversations in the adult world, we don't yet have a risk score, at which in the adult world there's both the REVEAL score as well as the European score. But I suspect in the years ahead of us, that's what's coming our way, where we'll turn, again, all the clinical criteria that we've identified as being important to decide low versus high risk into, again, a clinical risk score similar to how the adults are using that to help then guide decisions and choices around medicines, when to bring them in, when to move forward for particular people sitting in those middle grounds, not to miss an opportunity to be on more medicine to help improve their long-term outcomes. So that's what's also really cool, is that we're building in these risk scores, not a score yet, my apology, the risk idea into it. I didn't show the risk table, but certainly this article is available online, public use, and I certainly could get it all distributed and available to you as well. But it does have certainly some of the things we're looking for that makes patients really have a more of a low risk versus a high risk profile. So, all right, moving into therapies, which I think really is what many people had hoped to chat more about today. We talked about how we're going to build them in. Let's talk about the therapies themselves. This is a timeline which I always find really exciting, to be honest with you. Because it reminds us where we came from. Before 1995 in this world, we really didn't have a lot to offer people with pulmonary hypertension, oxygen, digoxin, diuretics, which were really, though helpful medicines, didn't really change the disease course itself. And so really after that, you can see with the introduction of epoprostenol, or many in the room may know it as Flolan, really changed the lives of patients with pulmonary hypertension, because it was one of the first drugs to really contribute to really pulmonary vasodilation, allowing those vessels of the lungs to be changed by a drug. And then after that, here's where it gets really exciting. 2000 all the way up to 2015, you can see the introduction of a large number of additional new drugs, of which are options as care providers in pulmonary hypertension has really expanded tremendously over the last 15 years. It's very exciting. So hence, again, the need for these fancy algorithms to decide how do we use them, how do we use these tools that we have in the right way. And not on this table is, again, our newest person on the scene, which is sotatercept, that just, again, came out for us this summer. So this is looks, I appreciate, very, very science-like. So if you're thinking you're in your science class, all of a sudden, don't get thrown off. But it's a diagram that, truthfully, you probably have seen on the internet, because it does come up quite often. It's out of a fairly well-recognized article looking at, hey, shoot, where do all these drugs work? And all those drugs we looked at really can be divided right now into targeting three main pathways to help the blood vessels of the lungs relax. And those three pathways really focus on either endothelin, nitric oxide, or prostacyclin. And I won't spend too much more details on it, but certainly that's really where the mainstay of our drug options really exist right now, until, of course, sotatercept, which is, again, the new kid on the block that's really approaching things through a different way here. We'll talk about that. This is a table just looking at, hey, shoot, what drugs do we have and where are they actually approved? And this is always a humbling table for us when I see it, because it reminds me of, again, how much we're using these medicines off-label in pediatrics. There are a number that are approved in the European medical, or in Europe, and then only 2 agents that are formally approved by the FDA for pediatric use, which is sildenafil and bosentan. And then in Canada, we're not in that table because, discouragingly, none of our medications are technically approved by Health Canada for pediatric use. It's all off-label use. Fortunately, in Canada, we have really nice avenues to be able to access these medications for pediatrics, but unfortunately still, based on the way Health Canada is structured as a regulating body, none of the medications are formally approved for pediatric use. So moving forward, as I'd mentioned before, I'm really going to talk entirely about off-label use of these medications. Just organizing those medicines in just a little different look of, hey, shoot, how do we actually give them? And so you can see the majority of the medicines that we have are really oral therapies given by mouth, tablets or suspensions for those younger kids where the tablets are too hard to take. And then we have some that are offered as inhaled, as well as continuous IV or subcutaneous therapy. Now, in Canada, we don't actually have access at all, even in the adult world, to inhaled therapies, particularly inhaled prostacyclin therapies. And that's for various reasons through Health Canada's explanations, but certainly, again, if it's something you're looking through the U.S. literature, that's, again, those drugs are available in the U.S. Now, there's 2 I wanted to spend some time on today because they are a little bit on the newer side. I think most in the room know them fairly well for the faces that I can see here. But I wanted to spend some time talking about macitentan and selexipag. So for each of these drugs, I was going to really kind of go through the backbones of them, just to give everybody just a feel of who they are, knowing that I appreciate many in the group already know or have had experience using these. So for each of these drugs, we'll talk a little about what they are, how they work, how we give it, some of the side effects, and a little on the pediatric experience and how that's growing. So macitentan, again, belongs in the endothelin receptor antagonist group. So again, like bosentan and abrasentan, it works very similar. But what is its claim to fame? Why is it so special? Is that it's, again, a dual endothelin receptor antagonist, so it can block both of the endothelin receptors, but it really is got its name because of its selectivity for endothelin receptor A. And that's really, again, some of the literature suggests from the pharmacokinetics that it really almost has a 50-fold preference for that receptor. And why is that so exciting? That's the receptor that ideally we feel should be the one to target to really get the best bang for our buck out of this pathway in terms of helping people with pulmonary hypertension. So it's, again, same part of that same family, but has this special, unique feature about its selectivity. We give it as tablets, similar to bosentan and abrasentan. The tablets are really quite tiny. Most kids don't mind taking these. Technically, there is no available suspension. I'm looking in the room that people know certainly that we have ways in pediatrics that we've given these medications very, very much off-label, I acknowledge, but to children where those tablets or the sizes in the tablets available weren't quite the right doses to match their body weight. The ranging is anywhere from 1 milligram up to 10 milligrams, and we dose this based on weight ranges. And it does, like all pulmonary hypertension medications, need to be uptitrated. We can't start at the full dose. Otherwise, again, the side effects that we would get with that would be really challenging to manage. So we start at lower dosing and slowly move our way to the full dosing for the child's weight. Side effects looks very similar to that of bosentan and abrasentan, headaches, nasal congestion. Some kids have struggles with some heartburn or stomach upset, a little bit of flushing. And this is another medicine like bosentan and abrasentan where we do have to watch the health of the liver with lab work. Fortunately, it doesn't tend to bother the liver too much, so the frequency of the lab work can be a little less often in comparison, particularly to bosentan, where we have to be certainly the most vigilant with the use of that medication and watching the health of the liver. The other big thing about this medicine that really got the adults exciting is it really has less association with edema, so swelling of the hands and feet. And I don't think that's a side effect that we've really had as much trouble with as the adults in using the medicines from this family, but this is really what got people excited about this medicine, particularly on the adult side, is related to that improvement in that side effect particularly. Now, the pediatric experience, there are certainly some published small cohort studies that show, yep, it's a safe drug, and it really does show that it is effective or works well in pediatrics, but we're really still missing that larger study to look at, again, safety and efficacy, which is what's underway, called the Tomorrow study, and it's, again, I think enrollment, if I believe still listed right now, should be closed sometime, I hope is in the next year for that study. It's a phase 3 study, and so the hope with closure will have not only evidence around safety, but also how well does it work in comparison to the other options on the market, abrasentan and bosentan, in terms of the other endothelin receptor antagonists. So that should come, again, almost closed off, so hopefully we'll be able to get that information from that study here soon. Good. I won't talk a lot about this medicine, but I think it's important to just bring it up because I do get questions about it from some families. And so there is a medication where they have combined macitentan and tadalafil, which again, many in the room may have heard of tadalafil. I'm not going to speak as much about it. Another common medication that we use to manage pulmonary hypertension. And so it's a combination where macitentan and tadalafil are together in the same tablet. We don't get to use it as much in pediatrics because often the dosing that's set in this tablet is really set for an adult-sized child, which again would really mostly be our teenage children. So we don't get to use it as often. And the other trick in Canada that unfortunately isn't really easily publicly funded, so it would need to be funded through your private insurance plans. So we tend to really not use this as much, but hey, shoot, the teenagers do ask me about it because it does make it a little bit easier to remember both their medicines if it's really all together. But nice to hear about it, and the adults certainly have integrated into their practices as well. Next medicine is Selexipag that I wanted to talk about. I think it's not necessarily a new kid on the block, but it's been around for also a shorter period of time and certainly has made quite a difference in pediatrics. And so Selexipag really is targeting that third pathway that was on the furthest on the right, which is the prostacyclin pathway, which again, typically when we talk about prostacyclin therapy, we're talking about IV or subcutaneous Remodulin. That's usually the drugs that we're looking to, and that's really all we had available for the longest time until Selexipag came on the scene. And so these medicines really work by stimulating that particular receptor, IP receptor, and again, when we give Remodulin, we're providing prostacyclin to stimulate that receptor, but with Selexipag, actually the drug itself will stimulate the receptor. So the hope, again, through it all is to have really less of the systemic side effects that come when we're giving IV or subcutaneous Remodulin. And I think clinically we've seen that the strength of this medicine probably isn't quite the potency of IV or subcutaneous Remodulin. So it's another tool in our toolbox, but does it replace IV Remodulin or subcutaneous Remodulin? No, we haven't quite found that because it just doesn't quite do the same job in terms of how strong it can be in stimulating that receptor. And so, but that, again, for us, the big advantage of it is, hey, shoot, it's not a subcutaneous or IV infusion. It still allows us to target that pathway to really help, again, change those pulmonary vessels. So this drug is certainly also unique in its own way. It's also given by tablets, and it has really truly a fancier uptitration than some of the other medicines, similar to prostacyclins. If we went all the way and started at the full dose, the side effects would be unbearable. But if we start at a small dose and slowly work our way up, we can, again, often get kids to a place where the drug is really working quite well with side effects that are manageable. And so I'm just showing you sort of the first 4 steps, which is what's proposed in the adult uptitration. In pediatrics, I do find we have to modify this quite a bit based on the size, the weight, the age, and how well the medicines are tolerated. Rather than the fixed uptitration set out in the adult protocols of almost an increase every week. I do find that kids often need a little bit more time to adjust to this medicine and its side effects. Side effects are, as a prostacyclin, working in that pathway, stimulating that same receptor, looks very similar to that of Remodulin, but tends not to necessarily be as strong or as much of a problem as when we're starting Remodulin, but similar side effects to the subcutaneous or IV Remodulin patients. And so what do we see? Headaches, jaw pain, flushing, bone pain, and then GI upset, which would include stomach pain, nausea, and vomiting and diarrhea. So these are all the same ones that we see along with Remodulin, but we tend to find they're a little bit milder, and we can often go a little bit slower in the uptitration, so they tend to be tolerated, again, and get settled out a lot quicker than what we see in Remodulin. So the tablets, I do get asked that by a lot of families because we do the uptitration with these tiny little 200 milligram tablets, which really, when you're getting up to the higher doses, ends up being a bit of a handful of medicines to take as to what do we do when we actually get to the real dose. And certainly Selexipag's created a beautiful color-coded diagram. I always can never remember the color-coded myself, so fortunately the numbers are also on them to help, again, when you get to that full or maximal dose, then you can switch over to a single tablet. So again, making that easier to give and take every day. This medicine's taken twice a day. I didn't mention that, rather than macitentan, which is a once-a-day medicine. Yeah. In terms of the pediatric experience, what do we know about this medicine? Certainly it's been integrated in the pediatric setting very quickly because, hey, shoot, if we could reduce the number of kids on subcutaneous or IV Remodulin therapy, that would be a really big change to quality of life. So it was really integrated quite quickly into pediatric experience. We have a number of smaller cohort studies, of which we have a Canadian experience published as well here through a number of the pediatric centers that involved and participated in that study that Dr. Bates and I had done. Looking at the use of it here in Canada. So we have a number of small studies showing that it is safe and it is effective. But again, for this drug like macitentan, we're still in the process of enrolling in a larger trial to really get a bigger, broader spectrum of how well is this helping kids with pulmonary hypertension. And so that study is the SALTO study, which also is in enrollment and hopefully also should close sometime in the next year if enough patients are able to be enrolled in that study. Last but not least, I wanted to talk just a little bit of sotatercept. It's again already gotten quite a bit of airtime here because it's really exciting, as everyone in the group probably knows. Shoot, in early September it was approved by Health Canada and is marching its way down the pathway to again meet the other milestones that it needs to do in order to be available for patient use. And it's an exciting drug, and I think it's nice to talk about why. This is the adult study that really has driven its acceptance by both the FDA and Health Canada. And it's an adult study called the Stellar study that really did show an improvement in many of the outcomes in the patients on this medication. Now, how does it work? This is what's really, really cool. Last time we talked about all those other drugs, we really are targeting those 3 pathways that help really open up the pulmonary vessels or cause pulmonary vasodilation. This is the first drug that we have available to patients with pulmonary hypertension that really is doing things differently. And so it really works through a totally different mechanism, and you can see on the diagram there, it's technically labeled an activin signaler inhibitor, which sounds like, oh gosh, that's a mouthful just thinking about it, but it's really actually quite neat in this diagram. Activin is described by the little blue dots. And if activin has its way in patients with pulmonary hypertension, and it likes to really activate cells to really proliferate and really cause that thickening and the narrowing of those vessels that we're seeing in pulmonary hypertension, and that balance of, again, new cells versus, again, what we call proliferation, making new cells versus anti-proliferation, is really set off by the presence of activin along with a number of other growth differentiating factors. And so what's so cool, sotatercept, it's displayed in this picture as the little red Y, and it's kind of like a mop almost, and it goes around and traps or captures these little blue activin and other growth differentiating factors, so it can actually bind to that receptor, thereby, really reducing the activity of that cell towards proliferation or thickening up of the tissue of those pulmonary vessels. So it's really one of our first drugs that, instead of by causing pulmonary vasodilation, which is really I take the medicine, the vessels are stimulated to stay bigger, and then when I stop taking the medicine, all of those vessels are going to go back to their regular size. This is one of the first medicines that we've had that is kind of encouraging that we may actually alter the disease itself in a way that really is, when you stop the medicine, there may actually still be ongoing effects of the medicine and how it's really changed where the disease is going. So very much exciting, and certainly the terms disease-modifying agent is certainly is being tossed around, but not yet. We don't yet have the data to prove that yet, and that's what's going to be exciting about this drug is figuring out, does it actually really modify the disease itself as the theory would suggest. So that's why it's certainly getting a lot more attention, particularly from pulmonary hypertension care providers, because it may actually offer a whole new course and trajectory in terms of the disease for the patients that we work with. So how is it given? It's given as an injection, subcutaneous, so under the skin, not in the muscle itself, every 3 weeks. And how and where you give that is a bit variable in each center right now, so I won't put that on the line, but in particular in pediatrics, you can imagine we'll be a little bit more cautious about how and where we would do those administrations. It's dosed also by weight, even in the adult world, and it does need an up titration, so you start at a lower dose and then go up to the higher dose. Right now in the adult world, it's really set as a 2-step, so low dose and then full dose. And in pediatrics, we're going to ultimately sort out if that is the best up titration schedule for pediatric patients too. Side effects, this is where things change a bit. It's a totally different mechanism, so you can imagine the side effects are going to be a little bit different for it all. The trick about that mechanism is that those activin and those growth differentiating factors also do some other important pieces. And so they have found increased rates of particularly bleeding, and I think that's important that we bring that out, because in pediatrics we're going to have pretty low threshold on how well we're going to tolerate that side effect, in particular on other patients that may also have bleeding risks on their Remodulin infusions. So bleeding is a risk, and with that comes this other piece called telangiectasia, which, again, if you haven't heard about that in the room, it's really a change to the smallest blood vessels in other systems of the body, not necessarily the lungs themselves, where they might put those vessels at a little higher risk of bleeding themselves, makes them almost a little bit more fragile. And so that's something that we'll watch for as well. Decreased platelets, which is the sticky part of our blood, that also can happen with this drug. So again, that bleeding risk is really increased by a number of pieces. And then the last thing that they've seen on the adult side is increasing hemoglobin. So that's the cells that carry oxygen in the blood. We've actually seen an increase in that on the adult side, which isn't necessarily going to be more of a trouble in pediatrics. Only those patients where we have holes in the heart, and potentially the kids are running and using those holes and running at lower oxygen saturations, where on a regular day their hemoglobin is higher than other children, where we may find that might stand out to be a little bit more of an obstacle for the use of this medicine than what we've seen in the adults, where they have really a smaller number of people with pulmonary hypertension related to congenital heart disease and holes in the heart. So interesting. It'll be certainly very important when we do start to use this medicine in pediatrics to really have some nice pieces in place to make sure we're watching for these side effects and have plans in place as to how we'll manage them when they come up. In terms of pediatric experience, that's where unfortunately I have to say we have really very limited. We don't have any small cohort studies, nothing published at this time. The Moonbeam is the study that's up and running, and it is enrolling. And so that's, again, a phase 2 study that really we're not sure the endpoint will be on that. So when we'll get the information from that will be a little bit unclear. There are some countries that are starting to use the sotatercept, where it's become available. In the US, if I, again, use them as our neighbor here, their FDA approval was a little ahead of ours, so they've been already starting to use it in some children in some centers. So I suspect just our collaboration, as I'd mentioned, through PPHNet, which is a collaboration through the US and Canada, I suspect with our combined experience, we might get to learn a bit from the United States as they move into using sotatercept in pediatrics a little bit earlier as an off-label drug. So more to come. It's really going to be, I think, an exciting year as we see more and more about what this medicine can do for pediatric patients. The last part, I'll just watch my time. I think we only have about 10 minutes, so I think certainly if there's questions I can stop. Otherwise, I had just done a couple of things around some newer entrants that I think some in the room are well aware of, some is not. But okay, maybe John, we'll do some questions just so I don't run out of time. I think there's a... I might not be on, just click this.
I'm just going to give you this so that the people online can hear you.
I'm just curious if you're going to be doing genetic testing like they were talking about this morning with regards to the Winrevair, whatever it's called. If we've already done genetic testing, if they've already tested for that gene, or if it's something we need to do again.
In terms of eligibility for the use of sotatercept? So it's certainly from what we've learned from the adult side already, there seems to be some patients that respond more notably to the medicine than others. And there is a idea that's building that perhaps it's related to either a genetic component or potentially BMPR2 particularly, or potentially it might be related to some other piece in terms of how do those genes then change the protein development or something else in those patients. And so at this point, there isn't any restrictions on what gene mutations need to go. You don't have to have a BMPR2 mutation to be considered for the medicine, which I think is a little bit about what you're asking me. So no, but is genetic testing really important? Yeah, and that's getting, I think, more and more important as we move along, because we're going to, I think, discover that there's probably certain pieces from gene mutations that might play into some people's response to medicine versus others. And that's a really cool, exciting area of research right now is, how do we use genetic information, and then not just genetic, but if I change over also into the world of transcriptomics and proteomics, which, those are, sounds like really terrible big words, Erica, but it's really cool. It's actually, how do the genes get converted into messaging to the cells, and then what proteins do those cells make, and how does that differ in patients with pulmonary hypertension, and then is there areas that we can make therapies to help change pulmonary hypertension, knowing how that happens. And so right now, sotatercept, doesn't need any particular genetic testing, but certainly many patients that are going to go on it, there'll be some encouragement, of course, to look more detailed at their genes to see if we can learn more as to, hey, shoot, if they're an individual that responds really well to it, how does that look? Now, is that going to be built into some of the studies? Probably not, but that's probably the work of these growing biobanks, where many families, likely many in the room, have been approached about being part of a pulmonary hypertension biobank, where your family or loved one with pulmonary hypertension has their genetic testing done in a very detailed fashion and stored in a biobank to then allow researchers to compare those genes and the information that we get from them to kind of decide, hey, shoot, how does that work? And we attach that information in a biobank to unidentified ways to the clinical information. So the researchers can then link, oh, hey, this individual that had this gene change had these clinical pieces that came with it. So I think that's the cool area of research. If we go along, I'll skip these two interventions. I'm pretty happy to answer questions about either of them. But the areas of research that people are really focusing on and what's really gaining attention and funding right now is projects around genetics, proteomics, and transcriptomics, as well as a little bit of work around the right ventricle. Those are some of the really kind of hot areas in research right now. And then the other one that comes up is this concept that's more global in medicine, which is the concept of precision medicine. And how do we aim drugs to really match the patient, not the patient group? And that's where those three fields of genetics and proteomics, transcriptomics, I think are going to help us define that over time. Is that a 5-year window? Probably not, but that's more of a longer window as, hey, where's medicine going? Is that individual or precision medicine? So it matches, your medicines match you as a patient, which is really exciting in pulmonary hypertension because we've seen that. We've seen patients that we've put on additional therapy and we've seen awesome things happen, but we've also seen in some other patients nothing happen. So we know it's a very real thing in pulmonary hypertension as a disease. The other cool thing about research, just while I'm talking about it, is certainly the other thing that's really important is getting patients and families involved. That's really a big part of research now, is really not just making sure we're getting good information and good answers for patients and families, but also making sure patients and families are involved from the upfront so that some of the outcomes that we're looking for are actually outcomes that mean something to patients and families. And so that's another big change that we're seeing in the world of research, is this shift to really collaborating with patients and families upfront in terms of some of the research designs and the outcome measures that we're using. So those are some of the big changes. Oh. Any other questions?
Yes. Sorry. A couple from online. Good question here. If a parent has IPAH, what can they do to see if the child has PAH too? Echo, EKGs, genetic testing, both. What do you recommend if they don't have any symptoms, but they're just a toddler?
And so just trying to have the question right, is about the screening for other family members for an individual that's been diagnosed with pulmonary hypertension?
Yes, idiopathic pulmonary arterial hypertension specifically.
And so most pediatric pulmonary hypertension centers will recommend screening for other family members, of which we call first-degree relative screening, meaning essentially anybody that's near to that individual by an arm's length. So brothers and sisters or parents in the setting of a child. And what's required for that screening is a little bit variable, again, but most centers now have come to a place where, again, a clinical review by a physician looking for any symptoms. Echocardiogram and ECG are the other two that are typically brought in, particularly in pediatric pulmonary hypertension, just given, as I mentioned, there's so many types of pulmonary hypertension associated with congenital heart disease. But even in new diagnosis of idiopathic pulmonary hypertension, those are really nice and important screening tests. The chest x-ray, again, is a bit variable and likely will be decided by the person that's working with you in the screening process to decide if that makes sense to do that additional testing. But usually, again, a clinical review, ECG, echo, and then after that, the other part that comes up, particularly in patients with idiopathic pulmonary hypertension, is this concept around genetic testing, which is typically offered to the individual with pulmonary hypertension first. And then if there's any mutations or changes that are seen in the genetics of that individual, then it would then be offered to other members in the family to look for those same changes in the genes. So that's usually where most of us start. So the lab work is mostly around genetic testing. Some places will build in some extra lab work looking for other types of pulmonary hypertension. But if the other individual or sibling is a younger patient, typically the additional lab work isn't necessarily required unless there's other concerns on the rest of the pieces that you've completed to screen for those diseases. And then screening, just to mention one more thing, it's often people feel, hey, it's a one-time check-in, but often if for idiopathic pulmonary hypertension particularly, we often will offer ongoing screening for those members, just knowing that we don't necessarily understand the trigger or the source of their pulmonary hypertension or the genetic contributors. So we often will offer ongoing screening through younger childhood for the siblings particularly, and then for the parents in the family, again, that screening really also it can be adjusted based on how and when the individual in the family that's diagnosed with pulmonary hypertension, how and when they presented can affect some of those decisions around that screening timing.
Awesome. Jeanette, did you want to add something?
I think here comes to the
No, I just wanted to add that, so at our center, we do continue screening usually 18 months to 2 years with the siblings, particularly those with idiopathic PH, whether they have symptoms or not.
Awesome, thank you. Another question online. Can you explain how AFR devices work?
Oh, yeah. Okay, great. Thank you to whoever that is. I appreciate I'm just going to go back on the slides. I'm not sure if they're still visible. But I had wanted to talk about AFRs because it really is a bit of a unique Canadian experience because there's limited access to this device in the US. And so in some patients, particularly with advanced pulmonary hypertension, this may come up in discussions about how, if the pulmonary hypertension is really quite severe and the pressures remain quite high in the heart, the right side of the heart has to work very hard. And often as pediatric care teams, we're looking at ways to preserve the strength of the right heart. And so by creating a hole between the top two chambers of the heart almost creates like a pop-off valve, sort of similar to the idea of a pressure cooker when you take off the top valve on it. And it allows the right side of the heart to really relieve some of that high pressure by pushing that pressure and blood over into the left side of the heart. But if you have pulmonary hypertension and you have no holes in your heart, well, that concept can't happen. And so for those patients that don't have a hole with advanced pulmonary hypertension, it can be considered that we can make a hole. And so the most common way to do that is an atrial septostomy, where we, in the cath lab, would go in and essentially create a hole between the top two chambers using a balloon and stretching and creating a hole. But the trick about that is that it really created an unpredictable size of the hole, which came with some particular risks that were challenging to manage. And so this device was created and is available in Canada through special access as well in a number of other countries, but again, at this point, not in the US. And what's the advantage of it is that it's actually a device that we can place between the top two chambers of the heart that has a hole in it. And so we can pick the size of the hole that therefore then matches the patient that we're putting in to give us really, truly, it's a bit like Goldilocks, not too big of a hole, not too small of a hole, but just right, so that it acts as a pressure release for the ventricle, but doesn't, again, allow too much blood to be moving around between the two sides of the heart. So it's placed in the cath lab, not as a surgery, so again, reduces those risks for patients with pulmonary hypertension. And again, we have various sizes available so we can match them. I do get asked by families if particularly in younger kids, hey, shoot, if we put this in now, what happens as my child grows? And that's the one challenge with them, is that we don't yet have a device that you can expand the size of the hole as the children get older. So we do have to, in pediatrics, really have some forward thinking about, hey, shoot, what size of hole might we need now, but also in the long term. So we tend to, for those patients, make those decisions leaning a little bit more on putting a little bit bigger hole in, not with they're going to grow into it, but that concept of allowing us to have a little bit bigger hole as the kids go along so the device would work long term. So we can't take them in and out. Some people have asked me that and change it up to a new size, but rather we do pick a size up front that we're hoping that would again be helpful throughout the life of the child. So so pretty cool. Yeah, and we've published a small series through the Alberta experience on the use of these, of which again have proven to be quite safe. In the patients, again, were carefully selected for those for that indication. Do you want to speak to that, John?
So as Dr. Voorhees said, that if you don't have a hole, they put that in, but we also can do it the other way. So if the hole's too big, there are ways of using this, and we don't want to close the hole, but we want to have a pop-off still. So we would use this device to, it's called fenestration, to still allow blood flow through, but not as much as prior to, because the risk of having too big of a hole is that then you start to have blood flow going the other way, which is not what you would want. You can expand on it.
Oh yeah, no, that's great, thanks, Jen. Yeah, so the concept of downsizing for those kids who have a very large hole between the top chambers of the heart and have pulmonary hypertension related to the, again, congenital heart disease or an ASD, which is the name of that hole between the top two chambers, we can use the devices to really essentially create a smaller one but not get rid of it entirely. So yeah, so really, again, and it's been a really helpful device in a number of children that we've cared for in pediatric pulmonary hypertension.